Thank you so much. It really is a pleasure to be here. Thank you, Wade, for the very kind invitation. I bring you greetings from Canada. Our flags share similar colors, and obviously we also share similar ideas, so it's wonderful to be here. Wade reminded me that I was last year in Taipei 15 years ago, and as I visit Taipei again, I now remember how much I've missed Taipei, which is a fantastic city and wonderful country. So today I will talk a bit about facial pain and the type of clinical and research work that I do in Toronto. And because also there's a lot of learners in the audience, maybe I use a few slides at the end for some advice that I can provide to you as you make your career plans. I will tell you that I have now been faculty in Toronto for 20 years, and it's unbelievable how fast time goes by. So when I first started, it seemed that there was a lot to be done, and then all of a sudden you look and 20 years have gone by. So hopefully I can use some of my advice for your own benefit. Okay. So I want to first begin by talking a little bit about the concept of facial pain and how we study and classify it. So one of the important ways in which facial pain is classified is the concept of chronic orofacial pain, which is defined as persistent pain that lasts longer than 3 months and is present for at least 15 days per month. So like at least half of the time people have pain in either face, mouth, or the jaw. So there's two important ways in which this is studied. One of them is using the classification of the International Classification of Orofacial Pain, ICOP. And using this method, it is suggested that at least 10 to 15% of adults have orofacial pain. So it's a huge problem. 10% of the population, 1 out of 10 people will have orofacial pain. And this includes a wide variety of diagnoses, things such as musculofacial, so the persistent, constant pain that patients can have in the face, or neuropathic pain, some of which we are familiar with. There's another classification as well from the International Classification of Headaches criteria, ICHD. The most recent version is ICHD-3, and I will talk about this a little bit as well. So some important publications have arisen in this area. This one relates to what I mentioned, the ICOP classification, which includes 6 sub-themes and includes both benign as well as malignant conditions. So you can see in terms of relevance to neurosurgery, we have patients with so-called dental pain, temporomandibular disorder also relates to the face, orofacial attributed to lesions or diseases of the cranial nerves. This applies to us most directly. And it's important that these 6 concepts have been referred to, or 6 categories, mostly nociceptive neuropathic pain, but a new concept has arisen, and that is the concept of nociplastic pain, which is, I would say, a little bit unusual. We don't exactly know what that means, but it's sort of mixed nociceptive, mixed neuropathic. And one can think of it, for a better comparison, one can think of it of something like fibromyalgia in the area of the face. So then, as I mentioned, there's also the ICHD-3 criteria, international classification for headache disorders. And this is important because it has a particular criterion for the identification of pain referable to the cranial nerves. And this is where trigeminal neuralgia comes in. And we'll talk about trigeminal neuralgia, of course, in more detail, but it's very important to note that even with the best criterion that we have, something like trigeminal neuralgia is defined as a condition for which there's no other diagnosis where it fits. So there's still some sort of discrepancy in understanding of what this pain actually is. And these are the definitions of trigeminal neuralgia in terms of how it is subclassified into idiopathic, classical, and secondary. So altogether, we see that facial pain as a surgical condition can be, in fact, defined with respect to multiple subgroups and components, and distinguishing exactly where we are in this, large grid. How are we defining the condition is actually important, because a lot of patients are referred to with this condition of trigeminal neuralgia, but in fact they have another problem altogether. So then it becomes our responsibility to sort out through these diagnoses and find out who it is that we can help with surgery and who is it that cannot necessarily benefit. So within this classification of the ICHD3, we have classical trigeminal neuralgia, but you also have painful trigeminal neuropathy, such as one after postherpetic neuralgia and so on. And again, distinguishing these becomes very important. We also have glossopharyngeal neuralgia, referable to cranial nerve 9. And in these categories, sometimes there's discrepancy or inadequate understanding whether this is something that refers purely to the face or deep to the throat, and sometimes that diagnosis is not very clear. So at this point, my practice, after the time that I've spent looking after this condition, the key patients that I see are patients with facial pain, and I would say that's now comprising about 85% of my practice. So there's some common themes. The vast majority of patients are referred to me with the statement of query trigeminal neuralgia. These are patients I saw to have trigeminal neuralgia, referred for neurosurgery. They've always, most commonly, have had multiple assessments, and sometimes they come after many, many dental treatments and visits with dentists, and it's not quite clear what they have. And there's, in fact, some very interesting articles published. This one is published by a group in India, the group of Manjul Tripathi. He does a lot of radiosurgery. Wade, I'm sure you know him. So in this very interestingly titled article saying, "Please spare my teeth," they looked at 187 patients who underwent gamma knife radiosurgery for trigeminal neuralgia, and they asked them, what was their experience like? And what they found is that at least half of them, 55% of them, saw a dentist first before they seeing neurosurgery. 41 of them had a dental procedure, and for a total of 1.6 teeth that were extracted per person, and eventually they came to neurosurgical care. And of course, these patients were diagnosed with trigeminal neuralgia, but it is quite actually possible that they had poor dental hygiene and all kinds of dental problems because they could not look after the teeth properly because of pain. Another article titled, "No one truly understands what we go through and how to treat it." They asked, or they surveyed 300 participants through the U.S. Facial Pain Association, and these were patients purely with non-malignant pain, so that they did not have cancer pain, and they asked what their experience was like. And 5 main themes were identified. A group said that it was a failure from the very beginning. I had dental procedure and things went very badly. Most doctors don't have a clue of what it is that I go through. Very high degree of frustration. Lots of medications that they have been given. And finally, they seem to feel that one person has been found that actually listens to them and identifies their pain. And of course, in the U.S., lots of problems with insurance and referrals that become a barrier to care. So altogether, we talked about 10% of the population having a burden of headache and facial pain, which is very high. And of these, 2% have effectively purely facial pain, which is still very high. I mean, you can do the calculations as to how this would apply to Taiwan. But in general, we talk about trigeminal neuralgia being an incidence of 1 in 25,000. So we can see that the population of patients with facial pain is quite a bit higher. And let's compare that with other conditions that we treat in functional neurosurgery. 0.3% of the population has Parkinson's disease, 0.6% of the population has epilepsy. So the burden is quite a bit higher. And I have to say, it's a very silent burden because these patients do not come to care, as I demonstrated, quickly enough, and oftentimes they just sort of circle around and don't get a proper diagnosis for a long time. And it seems to me that we have constructed this sort of artificially dashed line. This arrow is sort of property of neurosurgery, and this arrow is the property of oromaxillofacial surgeons and dentists, and somehow we have this artificial barrier that prevents connection. So patients that have facial pain end up getting to be seen by people that don't know much about the brain, and that is a problem that we need to address. So I want to talk about two areas of focus and the treatment strategies and outcome. One of them is trigeminal neuralgia, and the other one is atypical facial pain. And I think we sort of all understand what this implies for patients. Okay, so trigeminal neuralgia, it is a condition that we refer to as a compression of the trigeminal nerve at its root as it exits the brainstem. It's a condition that we like very much because patients generally respond very well to treatment. So they come with extreme pain, and we're actually able to get them home pain-free. So it's very gratifying for patients and, of course, for us. Generally, we say that about 90% of patients end up with pain relief, and roughly 75% of them remain pain-free at 5 years. So this is really the best odds that we can give, and it's very, very good compared with other pain syndromes. There are some unique aspects to this condition. So very few patients with trigeminal neuralgia have some pain. Generally, their pain is like on the maximum on the severity scale. So greater than 9 or 10 out of 10. Sometimes patients, I used to stop them and say, you cannot have pain of more than 10 out of 10. But it's not unusual for them to say, my pain is 12, my pain is 15. Now it's like, fine, it's okay, I accept, because I know how much this means to them to have an extreme level of pain. As I said, the odds of helping these patients is quite high, and there is a risk of recurrence. And as we already discussed briefly, there's an overlap between other pain syndromes, so trigeminal neuropathic pain and so on. So there's important effort and time that needs to be spent so that we are able to purely diagnose the condition and find out what is the best way to treat the patient. So neurovascular compression refers to essentially a vessel that is compressing the nerve at the root entry zone. So for our medical students, they know already this is the pons in the brainstem. This is the nerve on one side, and we see how it crosses the cistern, the CSF space, unimpeded. And look on this side, there is the vessel loop that we see in cross-section that is effectively bisected. It's buried through the fibers of the nerve and compressing it. And this is what we refer to as neurovascular compression. So compression can be of multiple kinds, can be contact compression and frank distortion of the nerve, and this is really what we look for when we examine the MRIs. And it is very important to note that the degree of pain that patients experience is not related to the degree of contact compression or distortion. So a patient with contact could say that my pain is 10 out of 10, similar to a patient with compression that says my pain is 10 out of 10, and a patient with distortion that says the same. And once in a while, we see patients with compression, they've had an MRI for some other reason, they don't even have pain. So there's a lot of areas that we need to expand our understanding. And this also relates to an article, very important article published in 2009. We go back a few years now, where the group of Kim Burchell in Oregon looked at radiographic evidence of neurovascular compression in patients with and without trigeminal neuralgia. And their conclusion was that about nearly 20% of patients that have an MRI for some other reason, they don't have pain, they're asymptomatic, but they have neurovascular compression. Ipsilateral to the side of pain, the compression is seen in about 60% of patients, which means that the rest of them, 40% of them, don't have evidence of compression on an MRI. Now, you could say in 2009, maybe the MRI was not as defined as it is now, but still, it's not 100%. So this is very, very important to note that, and we have the diagnosis of idiopathic trigeminal neuralgia. We don't see direct evidence of compression, so that's important. And also, there's a group, there's a higher group of patients with bilateral evidence of compression, even though the pain is uniformly on one side of the face. So this is also a peculiarity of patients with trigeminal neuralgia that we need to understand. And of course, we talked about this. I want to point out a series of articles that we've published recently that discuss trigeminal neuralgia in great detail in Lancet and in Nature Review of Diseases. And also, this is very helpful to understand the best type of imaging that we can perform and how we can look after these patients with different types of pharmacological, non-pharmacological, as well as neurosurgical treatments. And the things that we look for, obviously, in addition to neurovascular contact, is unusual things such as dolichostatic loops. Here we see a very impressive compression of not just a small vessel such as superior cerebellar artery, but very large vessel compression, generally either the basilar or loop of the vertebral artery that comes up and compresses the nerve. So this is, adds an element of technical management of these patients, which is a bit different than the standard patient with classical trigeminal neuralgia. Once in a while, we have bony anomalies that may obscure our view if you're going to operate on these patients, and this is important to note as we look at the images. We can have tumors. This is an almost invisible tumor, but it's there, and it's sitting right at the root of the trigeminal nerve and compressing it. And rarely there can be things such as meningoceles inside Meckel's cave. In this case, it was compressing the fibers. You can see them distorted here. And the patient had actually very, very severe pain. And we had to drill the canal and enter Meckel's cave to release that compression. And the surgical treatment of trigeminal neuralgia, which I'll talk about briefly, primarily focuses on microvascular decompression, gamma knife radiosurgery, which is delivery of radiation to the cisternal component of the nerve, rhizotomy, and different types of neuromodulation that are very important. I'll talk about these very briefly. Microvascular decompression is an approach to the root of the trigeminal nerve, and we do this in our center. We do this with a retrosigmoid approach, accessing the cerebellopontine angle. Very important to be aware of the anatomy of the posterior fossa because this is a route of entry. So following this arrow all the way down to the root of the trigeminal nerve. And importantly, review and assessment of the venous sinuses is really important to keep the surgery as safe as possible. In our institution, microvascular decompression is done, as I showed to you. We map the area, so we use neuronavigation in every case, and we want to make sure that our access is not over, but just besides the sinuses, so that I place the burr hole just under the transverse and slightly far from the position of the sigmoid sinus, small craniotomy. And for these patients, we always try to minimize the risk profile by doing brainstem auditory evoked potentials to minimize cranial nerve deficits, neuronavigation to minimize bleeding, and I almost never take the petrosal vein, only because one cannot say 100% of the time, but it's really, really rare that one needs to take the petrosal vein. So this is a brief video of a microvascular decompression case. The trigeminal nerve is here. You can see that it's distorted. This is cranial nerve 7 and 8, and here we're performing a transposition. So you can see a substance of the pons here, and the vessel is just essentially stuck under there. And typically, these vessels that are transposed are bifid. So you see there's two loops of the SCA, and these loops have now been brought out. The nerve has been decompressed, and I place a piece of Teflon so that we minimize the contact between the vessel and the nerve, thereby allowing the nerve to rest a little bit and not have these pulsations of the vessel on top of it. There's also the rhizotomy procedure. So this is a long needle transcutaneous approach that aims for the position of foramen ovale, and we do this under fluoroscopy. Very important procedure, particularly for patients that are of advanced age, and maybe they're not the best candidates for microvascular decompression. A recent article published in World Neurosurgery in 2023, very, very helpful, looks at this radiofrequency technique and provides better information for landmarks. And a very important landmark of where we're approaching is that generally we need to be in front of the edge of the temporomandibular joint and the ramus of the mandible. This is really important to keep things safe because right behind foramen ovale, we're not too far from the position of the carotid canal. And of course, we don't want to hit the carotid canal. So again, by reviewing of the landmarks for our learners, this is the sella, and this is the clivus, and this line defines the petrous bone. And if you can see it, there's a V here that we can form, and this is where we are approaching with the needle. Gamma knife radiosurgery, very important technique for management of these patients. Is very versatile because the patients can remain awake the whole time. It's a frame-based procedure to maximize safety and maximize accuracy of targeting the trigeminal nerve. And if patients require, for instance, blood thinners because they have cardiac conditions and so on, we don't stop those blood thinners, whereas obviously for open procedures, or even for rhizotomy, those blood thinners need to be stopped. So in order to perform this procedure, we define volumes. So the volume of the brainstem so that we can calculate the dose and keep it safe, and the volume of the nerve as well. So very safe and very good procedure, single outpatient treatment. Pain relief is not immediate, that's very important to know, and roughly 80% of the patients are relieved of their pain. So in North America, we have a substantial case burden of patients with multiple sclerosis. I'm not sure whether that condition is prevalent in Taiwan, but I think the most the highest incidence is in northern climates where there isn't that much sun. So in Canada, we don't get that much sun. Level of vitamin D is very low, and as you know, vitamin D has been linked to multiple sclerosis. So Canada and Northern Europe have very high incidence. So we have a substantial proportion of patients with multiple sclerosis. And in these patients, the pathophysiology is different. It relates to plaques within the brainstem in areas of the that connect with the fibers of the trigeminal nerve. So we treat these patients, and an important part of our work has become understanding of the microstructure of the nerve as well as the brain, and connecting these with the expression of pain. So we've done that for patients with MS and also non-MS, and our goal is to move from these conventional images to one in which we're able to see the nerve fibers and study these fibers and draw metrics to understand what happens to these patients when they have pain. So in patients with MS, we see that they have this MS plaque here, and we know where the fibers of the trigeminal nerve are meant to go. And as part of our work using diffusion tensor imaging, we study these fibers to see what happens to the areas of the trigeminal nerve that are right beside the plaque versus the cistern and so on, and distinguish these between patients that have have trigeminal neuralgia, that is the classical form, versus MS related. And in a recent publication, we looked at these plaques within the brainstem of patients that have MS and mapped the fibers of the trigeminal nerve on top to demonstrate that, in fact, the vast majority of patients have bilateral plaques, but the expression of pain is unilateral most of the time. And therefore, this means that some plaques are active, some plaques are in the process of remyelination, some are in the process of dysmyelination, which is abnormal remyelination. And understanding how these plaques impact trigeminal pain is obviously very important. There's another condition that we defined a few years ago called trigeminal neuralgia associated with a solitary pontine lesion. This is a very unique condition that we were able to describe. So in these patients, we see that they only have this one plaque within the brain. Very, very unique structure that is there in an unexpected manner. Their presentation is entirely in keeping with classical presentation of trigeminal neuralgia. But then when we examine the MRI, we see this lesion there. And again, we look at patients with single pontine lesion. They have this thing. Classical trigeminal neuralgia patients don't have any defined structural abnormalities. Then we have patients with MS, which have multiple lesions. That's by definition, multiple sclerosis has multiple lesions. And then there's a series of criteria that these MS patients have that they need to meet those criteria to be diagnosed with MS. So it's a very unique syndrome. We have termed it accordingly, and then what we did is to study its imaging characteristics. One of the characteristics is that this lesion is actually best visualized on T1 images, and sometimes we can't quite see it on T2. So very important to study these all sequences on the MRI to understand this. And then we studied the microstructure of these lesions to demonstrate that in fact it's different than patients from MS. So when we look at fractional anisotropy or different measures of diffusivity, there's a difference comparing with those with MS. We don't know exactly what this lesion means, what is its pathophysiology, but we do know that the fibers map to the positions of the trigeminal fibers within the brainstem when we do lesion mapping. And the other important thing to note is that the response to conventional surgery is actually rather poor. So these patients have treatment again and again and again. They get better, the pain recurs. They get better, the pain recurs. So compared with 85% of patients with trigeminal neuralgia having good relief after surgery, a good number of patients with MS-related trigeminal neuralgia as well, these patients have very poor response to conventional treatment, at least long-term response. So this is actually very important to note and to discuss with patients up front so that they are aware that their expectations should not be exactly the same as with other patients. And in fact, one of our former fellows, Christian Uriel Morin, in Quebec, Canada, the French-speaking part of Canada, has recently started a study whereby they put in a DBS electrode, transcerebellar, in the area of the pons where this lesion is to stimulate it and attempt control of patients' pain in that way. The other condition that I want to discuss with you is this notion of atypical facial pain. As I mentioned, a very high proportion of patients that come to clinic thought to have trigeminal neuralgia, but then when we talk to them, we see that their patient is very different. Generally, these patients complain of constant pain. They have dysesthesia, burning pain, tingling. Very common for them to say, I went to the dentist, I had some maybe mild problems with my tooth. The moment they did the injection, I almost jumped off the table. It was really, really bad, and sometimes for years the pain has not settled yet. So they're able to have a temporal association between dental treatments, that's very common, endodontic treatments, root canals, and so on. And it's most frequent with the lower molars, particularly at the back, the wisdom teeth. And of course, the conventional surgical treatment is not reasonable for these patients. And so this is, for instance, of an article that was published of nerve injury in the process of endodontic treatment. Very unpleasant to look at, but this is what they have to deal with. So neuropathic pain post-dental trauma results in atypical facial pain. I see patients that have had corneal neuralgia, post-laser eye surgery, facial pain after sinus surgery performed by ear, nose, and throat specialists, facial trauma, facial reconstruction, jaw advancements, and so on. So these are all possible causes for atypical facial pain. Now, you might think that corneal neuralgia is very unusual. It is very unusual. It's seen in about 0.1% of patients that have laser eye surgery. But when we take into account how many patients have this treatment per year, it actually is an important population of patients to look after. So in these patients, we consider neuromodulation, and this is based on a Tasker axiom. Dr. Tasker was really the father of neurosurgery in Canada, and he was an amazing researcher who studied pain in the thalamus. This is from his book. And he said that when pain is a result of nerve injury, further injury to the nerve is unlikely to result in pain relief. So in these patients, we give great consideration to neuromodulation. And this can be in the form of brain stimulation. This is an area that we target very commonly for Parkinson's disease. Of course, it would not be the same target for these patients, but we are very familiar with the technique. So there's a variety of techniques that one can use for neuromodulation, either central or peripheral targets. And I want to focus on the peripheral targets, particularly peripheral field stimulation, which is an emerging procedure for the management of these patients. This is a percutaneous approach where we install the electrodes in the field of pain, and not necessarily stimulating the nerve, but stimulating the field. So the patients identify the place where the pain is dominant, and that defines the anatomic zone where we deliver the stimulation. And this is generally done in two settings. The first is a trial, which is done under general anesthesia. We define the area where the pain is, and we place a subcutaneous electrode, which they then hold on to for the period of about maybe a week or 10 days. And we study what the benefit of these electrodes are during that time, and if it's successful in covering the geographic area of pain and providing them with at least 50% relief, then we move into permanent implantation. So again, the patient can define and say, for instance, the pain is in my forehead or in my cheek or in my jaw, and that is the area where we define the position of these electrodes. So this is a view of the trial. The patient's face is actually quite accessible to us during surgery, and through a very small incision, we place the electrodes, and once these are there, again, just a percutaneous placement, we connect it to a setup that allows us to set the patient with a number of programs, and then they go home with those programs, and we see them in clinic about 1 week or 10 days later to determine what the effectiveness is. A few contraindications: if the patient is completely diaphoretic, meaning the face is completely numb and there's nothing to stimulate, there's no fibers, that's quite unusual that the patient has no sensation at all. Oftentimes they say, you know, my face doesn't feel normal, it feels very numb, but they actually have some preserved sensation. Relative contraindications would be pain that is located very medially in the face, and therefore it's very difficult to reach with the electrode. So if they say that the pain is in the nasal fold or just at the side of the eye or intraoral, then it makes it very difficult to reach that space. And of course, patients that have corneal neuralgia, it's important to have this conversation with patients. We generally put in 2 electrodes, one above the eye, one below the eye, and hopefully that helps control things, but it's very difficult to predict how effective this might be. We published a study assessing, it was a meta-analysis to assess the clinical outcomes and complications of peripheral field stimulation in management of facial pain. And the studies that we reviewed suggested that at least 76% of patients stopped taking medications, 86% of patients had a successful stimulation, and their pain improved by about 75%, or mean difference of 6 points on a 10-point scale, which is very, very good. Because the electrodes can be mobile, there is a risk of surgical revision with electrodes moving out of place and so on. So this is important to note. So these were the studies that we looked at with the assessment of pain improvement in all of these studies and a pre-op versus post-op pain score for these patients. Deep brain stimulation is an option as well. The classic target has been sensory thalamus and periventricular gray, which provides some benefit, even though the benefit is not ideal. I mean, there's been studies that suggest that the likelihood of having long-term benefit from deep brain stimulation, strictly using these two targets, is about 30% in the long term. So that makes it possibly not an ideal setup, given everything that is involved in this procedure. And therefore, we have moved to understanding and studying the networks in each patient to see what are the key networks that are helpful in the expression of pain. Is it, for instance, more sensory networks versus areas that are important in the modulation of pain? Or perhaps for certain patients, it's more of the limbic networks that are involved in them effectively suffering from pain. So this is something that can be done, understanding the networks that are important for each individual, and therefore individualizing treatment. And this comes at the expense of a significant burden of work for the study and analysis of data. We've done one patient now that we studied with SEEG electrodes to understand the networks, and we had a very successful outcome in that patient, but again, a very work-intense effort to understand these patients. So I hope that in summary I've been able to deliver that the burden of facial pain is large and mostly hidden. There's a substantial number of patients that are getting suboptimal care and not referred for neurosurgical treatment within an adequate span of time. Let's think, for instance, comparing this with another surgical indication. If a patient comes to us with sciatica, and we talk to them and so on, it's possible that they say, I've had this pain for weeks, I've had this pain for a few months, it's very severe, it's terrible, I can't work, I can't walk properly, and so on. And then we assess and potentially recommend surgery. Maybe it's different here, but certainly in Canada, where I see these patients, it's not unusual for patients to come with facial pain and say, I've had this pain for years. There's years that I've suffered with this pain. No one seems to understand. I don't know what to do, and so on. So it's unbelievable that for a condition that we know responds so well to surgery, patients still have such delays in referral. There is, in fact, a significant discrepancy as well. We've published on this data between referrals for males and females, with males being referred much faster for neurosurgical assessment than females. Many factors, we can talk about that at a different time, but this also needs to be noted that not everyone gets referred at the same with the same referral pattern. In my view, the spectrum of surgical treatments that I've offered these patients is best offered by functional neurosurgery. And of course, adequate diagnosis is needed for the definition of the best surgical procedure for these patients. We should not recommend the same procedure to an 85-year-old that has trigeminal neuralgia versus a 55-year-old that has trigeminal neuralgia. We need to have a spectrum of procedures available. Obviously, patients with classical trigeminal neuralgia with someone that has, say, pain after dental trauma, different procedures are available. And of course, the advances in imaging and understanding of networks is very important in both providing the best treatment and the most individualized and ideal treatment for the patient. So at this point, if we have time, I just wanted to share some of my thoughts for our residents and learners. I call these partial chronicles because I still have a few more years, I hope, to develop these into the full chronicles for what I have learned in my career. The first is that we grow by connecting the dots. So Kierkegaard, who is a famous philosopher, said that we understand life backwards, but we must live it forwards. And this is a very interesting work of art performed by this author by the name of Kumi Yamashita, and this is all connecting dots. These are all tiny little nails, and the connection of the dots has resulted in the formation of a beautiful figure. And this is really what we do with our lives as well. We connect dots and we understand them, looking backwards but moving forwards. It's incredible how important it is to recognize opportunities. When I started in the area of my work in trigeminal neuralgia, it was when we first got our Gamma Knife machine, and now a few years back, and we had referrals for trigeminal neuralgia and so on. And this became an incredible opportunity. It's a great condition. My work was primarily movement disorders at the time, but then slowly, this notion of how we can best identify patients and look after them grew into what it is today. So I was fortunate to recognize this opportunity. This, as an example, is a tree burl. It's actually a tumor within a tree. It looks unsightly. You know, if you look at a beautiful tree and suddenly you see this mass in there, it's like, well, that doesn't look very interesting. But you can make an absolutely beautiful pattern out of that once you drill it appropriately. So this is, in my view, a good example of how we can recognize opportunities. It's really important to have a mentor. I was very fortunate to find my mentor very early on when I was actually, before I was in medical school. Dr. Andrew Talala was a pioneer in the field of neurosurgery, and I learned so much from him. And sometimes I think to myself that had he been a pediatrician, I would probably become a pediatrician. Had he been an anesthesiologist, I probably would have become an anesthesiologist, because he was such a mentor, and I just learned so much from who he was as a person and also his wealth of knowledge. If we are lucky, then you will have more than one mentor. And if you're also lucky, the voice of your mentor will stay with you. I think that's probably the best way I can define a mentor. Who is it that their voice stays with you years after you have moved on? So I can mention a good number of mentors in my life, and I really do think of how they've approached cases and how they've analyzed and what have been the key aspects or the key attributes of their personality that allowed them to do what they've done. And it's wonderful to think that we come in contact with these mentors nationally and internationally, and what we learn from them. So very, very important to seek mentors. It's good to have a sense of humor. Sometimes we think something is going to be easy, and it's not, but it's okay. We persist. And it's also really important to put life into perspective. This is a quote attributed to Einstein, who said, "A human being is part of the whole, called by us the universe, a part limited in time and space. He experiences himself, his thoughts, and feelings as something separated from the rest, a kind of optical delusion of his consciousness. This delusion is a kind of prison for us, restricting us to our personal desires and to affection for a few people nearest to us. Our task must be to free ourselves from this prison by widening our circle of compassion to embrace all living creatures and the whole of nature in its beauty. I think this is really, really important because we need to, you need to, as the young people in the audience, change the future, working from where we are and advancing it further. So that means that you have to think ahead and think of things that have been done and how those need to be improved upon. It also relates to the neuronal theory of Ramon y Cajal. If you know the history of neurosciences, you will remember that in the early 1900s, Ramon y Cajal, the Spanish neuroscientist, described the neuron as a single independent entity. And slowly we went from that independent entity to understand the context, and now we focus not so much on a single neuron. Obviously, if we want to study neuron, there's still a lot to be learned, but to understand networks. And what a great similarity to think of the world. We are all, as individuals, independent entities, but we function with each other, connecting with each other, connecting internationally, Canada and Taiwan, and so on. And that is really how we learn and we grow, not only by focusing within ourselves, but focusing outside of ourselves, looking at those around us. And as physicians, this is the core of our lives as well, focusing on helping other people and not so much on ourselves. And this is a picture of Ramon y Cajal, his beautiful drawings, and Golgi, his co-sharer of the Nobel Prize, with whom they had great level of antagonism. Golgi thought that the neuron could not be a single independent entity and that the whole brain functioned as a syncytium, yet Ramon y Cajal used a Golgi stain to prove that in fact the neurons were independent entities. So the story is that Golgi refused to shake his hand, Ramon y Cajal's hand, at the Nobel ceremony. But anyhow, we've learned a lot since then, and at least 100 years have gone by. Sometimes there will be doubts. This is my favorite sort of description of this. Is called The Private Doubts of Christopher Columbus, a very old cartoon that was drawn about him heading towards America and looking at the horizon saying, well, it sure looks flat. Where am I going exactly? I think it's okay to have doubts. It's, no one really furthers themselves by not having doubts. The issue is how do we manage the questions that we have in our head, and how do we have the cognitive flexibility to assess our situation and determine what is the best next step to take. I had when I was in undergraduate, I did my undergraduate in biochemistry, and I had a professor that I was not particularly fond of him for a number of reasons. And he always used to talk about serendipity in science, about how things happen just by chance. And I would think in my head, and I would say, like, how can I rely on chance and hope that something, suddenly lands on my lap? And somehow life has taught me differently, because so many steps in my life have been directed by serendipity. Things that have happened that I, did not expect, but they ended up being amazing events. And of course, we can't seek serendipity, but in my mind, we have a landscape of opportunities, and serendipity is essentially recognizing an opportunity. Maybe I've recognized a few and I've let go of a million. It's possible. But let's not turn serendipity into missed opportunity. Very, very important that when we see opportunity in front of us, we recognize it. And I think this is also really important. We define as success, and obviously we all want to be successful, but pursuing success is a challenge. This is a really, really important book, very influential book by Viktor Frankl, who was a psychiatrist, and he survived the Holocaust to write a book called Man's Search for Meaning. And in this book, he said, don't aim at success. The more you aim at it and make it a target, the more you're going to miss it. For success, like happiness, cannot be pursued. It must ensue. It is the unintended side effect of one's personal dedication to a cause greater than oneself. So rather than looking for success, look for a goal that drives you, and then if you pursue that goal with diligence, hopefully success will accompany it. Otherwise, we're sort of chasing a cloud that leaves our hands. And think of the work that we do and the advances in the world as art. These two paragraphs were written by someone by the name of Walter Benjamin, who was a philosopher in 1935. He was also an artist. And he said, in all the arts, there's a physical component which can no longer be considered or treated as it used to be, which cannot remain unaffected by our modern knowledge and power. Now think of how much life has changed since then. For the last 20 years, neither matter nor space nor time has been what it was from time immemorial. We must expect great innovations to transform the entire technique of the arts, thereby affecting artistic invention itself and perhaps bringing about an amazing change to our very notion of art. I would say we can take out the word art and substitute for science, and we will still have a very meaningful understanding of how much science has changed and what is to come in the next decades ahead. And at the end, remain curious, pick a lofty goal that will guide you through your life, have individual and collective responsibilities to your teams, patients, and of course yourselves. Above all, we need to really have a lot of respect for patients who are ultimately our foremost teachers, and they give us the blessing of being able to work with them to try to help them, and think of science and medicine as a life of service. So on that note, I really want to thank you so much for inviting me here to Taipei again. I'm so thrilled that I've been able to come. I have to thank EVA Airways for giving me a very long layover so I can come and visit you. And I want to invite all of you to the World Society meeting happening a few months from now in Marseille, and a great forum where we can share greater ideas in the field of stereotactic and functional neurosurgery. Thank you so much.
Thank you so much for your wonderful talk. And I think we have a colleague from the neurosurgery department. I think
it's really nice talk, and especially when me already do the downlab several years, so we actually done a lot of facial pain cases, and every time we face some cases, treatment failure, we will come back to see, on the diagnosis, maybe we should do more diagnosis or something. So the very first question is that you mentioned about some neuralgia and the painful neuropathy, no matter trigeminal or dorsopharyngeal. Do you think we can do, for example, ENG or MCV to do the differential, or what kind of symptom you think is most important when we do the differential diagnosis?
Diagnosis between trigeminal neuralgia and painful trigeminal neuropathy. So at the moment, that differentiation is purely on clinical grounds. So the expression of pain and whether it's constant pain versus lancinating pain that we generally see with trigeminal neuralgia. But you are correct, sometimes it's not clear. And I have gone through those same steps myself, and sometimes it's after the fact that we look back and say, actually, maybe that was not trigeminal neuralgia, because we have limited understanding of like if we think of it as a Venn diagram, there is a cross-section where it's not quite clear exactly what syndrome that we have. For instance, I have had, I can clearly mention several cases. I've had a patient who had the severity of the pain became relevant after she had a dental treatment. Before then, she really didn't have much pain. Then she had the dental treatment, and she had a background of pain and lancinating pain on top of that. We did an MRI, there's neurovascular compression. But she does not really have pain-free periods, which is something that we really consider important for trigeminal neuralgia. So after many discussions back and forth in medication, and she said, please, is there anything you can do to help me? It's like, fine. So then we moved in to microvascular decompression. No better. Very unfortunate, no better. And then, as I think about, in retrospect, like, well, she really did not have the symptoms that we would expect in trigeminal neuralgia. So it becomes very challenging in some cases. I can give you the sort of opposite of that as well. a patient that had a clear jaw abscess. The abscess was drained. Patient had treatment for, antibiotics for a long time and so on. And then had primarily lancinating pain, but also mild level of trigeminal underlying pain that was there as well. But because the lancinating pain was very severe and unrelenting, I decided to do a rhizotomy. It helped him initially, and then the pain came back, and he was so bad that he was in the emergency room and so on. And then I did another rhizotomy, and that the second time did not help so much. And then we assessed the MRI again, and I said, well, he actually does have neurovascular compression, and he was really, really desperate. And I said, well, at least we can do a microvascular rhizotomy, hopefully give him greater relief. And I was very impressed once we did the MVD of the degree of neurovascular compression. He was entirely pain-free after that. So then I scratched my head thinking like, well, what's going on? And sometimes we do have this situation where I think the nerve is actually sensitized at the root, and then a peripheral procedure happens that just brings on an exaggerated response. But how do we dissect these two components? It's very hard. And today I did not talk too much about the research that we're doing in this area, but a great component of what I've done is really change the notion that we keep chasing the concept of neurovascular compression. Obviously, it's important. We use that for surgical decision making and so on. But at the end, it's not the blood vessel that's important so much as the nerve. The pain happens because of the nerve, not because of the blood vessel. We've all been in meetings where we discuss microvascular decompression. What is the best way to look at the blood vessel? What degree of compression? Is it SCA? Is it ICA? Is it double loop? What do we do with, arachnoiditis, etc.? We focus on everything around the nerve except for the nerve. And my work has tried to change that by focusing instead on imaging the nerve and the microstructure of the nerve and finding features that allow us to understand what is happening at the root entry zone and how we can use objective criteria to define trigeminal neuralgia so that we have better assessments as we see our patients in clinic. So hopefully we will, there's obviously some elements that we know, for instance, how DTI can influence understanding of how gamma-9 has worked and it's likely to work versus patients that don't have relief, maybe because they've been underdosed. So all of these things, but the goal is that we slowly move towards a more objective criteria for understanding of the nerve versus just clinical subjective criteria, which render an element of ambiguity that's difficult to sort out.
So talking about the DTI, I'm really lucky that in Taiwan actually we have a very low incidence of the multiple sclerosis. Mm-hmm. But I'm very impressed in your article about the MS use the DTI analysis. Can we show the DTI slides? Because when I do the trigeminal DTI, there is important. When we translate, you will find some fibers just around the pumpkin surface.
Uh-huh.
Yes, maybe
this one?
This one.
This one?
No.
I think
this one.
Here?
This one.
Or this one?
This one.
Oh, yeah, okay.
You see, some has that you are tracing some fiber here.
Correct.
When I do the trigeminal DTI, I just told my technician why we have this one. It's not real, but this one I believe is real.
Yeah.
The nucleus is here, but why we have fiber here?
Okay, so yeah, that's a very good point. That has to do with the technique of imaging the nerve fibers, and so if we use conventional DTI imaging, which is essentially single tensor, the method is that the direction of the fibers is estimated as the best single direction within a voxel. So that is able to image these fibers of the trigeminal nerve within the cistern really well. Maybe I can point to it with a mouse better. Yeah, so these fibers within the cistern can be imaged really well, but as soon as we enter the brainstem, then that means we're entering an area where there's many different directions. So sometimes the software misrepresents the direction of a tensor for a stronger bundle that is very close. So hallucinations in DTI imaging is very possible. So it's not that patients with trigeminal neuralgia all of a sudden have this fiber. This is obviously hallucination. But this is done with actually multi-tensor imaging. And that's really the only way where we can image the fibers within the brainstem. So then what we do is, for instance, these fibers that actually belong to cerebellar peduncle, these are excluded. So we consider these as anatomically erroneous because they're not part of the trigeminal nerve. Yet we're at least able to image these fibers that are in the brainstem part of the trigeminal nerve, trigeminal tracts, and therefore we're able to see them. So similarly, this, and even these fibers within the pons and these ones, these are erroneous, anatomically erroneous fibers. So there's a lot of back and forth until one is able to image the correct anatomy and interpret it accordingly so that we know that we are really, taking measures from an area that is correct. So, for instance, the graduate students in my lab, sometimes they have to go back and forth between the imaging and the DTI assays that we use so that they are sure that the fibers that they're looking at are the correct fibers. Hopefully, when the technique improves enough, we can set up an automated method to minimize these distortions and hallucinations. I have seen, not necessarily in the context of trigeminal neuralgia, but misinterpretations of fibers that, frankly, I don't think they're necessarily anatomically correct, and there is, it can be a challenge. But that has to do more with the technique itself.
So I think our audience also include our medical students. So I'm just wondering if anyone medical student has a question for Hodaie. So you are year, I'm not sure, year 1 or 2 or 3, 4. So yeah, today's topic may be a little challenging. So if anyone has a question from students?
All questions are welcome.
Yeah, of course.
Of course, mate.
Sorry, I would want to ask a critical question, but I think because here is a medical student at school, so I think maybe I can share some of the advice for the medical students, or maybe for their future research. Especially in our school, we have a special program. We call it physical engineering program for medical students. They can study some of the engineering science, like in their curriculums. So especially when your research is involving a lot of image technique, and so for those students, do you have any advice that in the future, if they are interested with the brain science, the neuroscience, anything they can prepare or they can pursue for their future career, if they have some interesting to actually not only focus on clinical part, but on research or any although they're still very young and they're studying medical school, but I think a lot of students which I taught, they have already expressed their interest in to actually pursue some of the research career like the Hodaie do. So any advice where they can do some prepare for themselves or any study they can study in front is better. It's very useful for them to develop their career in the future. Advice.
Well, I would say that particularly Taiwan is a powerhouse. So you're very fortunate to have the power that you have in this country in terms of advances in science and technology and so on. As time has advanced, we also have, or maybe our new generation of students also have the benefit of greater connectedness between specialties. So medicine used to be its own world, engineering its own world, and so on, and even like, for instance, molecular research and so on, its own world. Now there's so much greater degree of connectedness. Sort of referring back to Ramon y Cajal, we're not just single neuronal entities, we work within a context. But these contexts are now being used in the definition of new programs that are interdisciplinary, for instance, combining engineering and medicine, combining molecular biology and medicine, and so on. So the best way is to really take advantage of such opportunities now, because now is the time that the students have to dedicate and understanding fundamental scientific techniques that will then hopefully illumine the rest of your career. It's a challenge. It's a challenge for all the students. How much as a student, how much do I stress myself to maximizing this and maximizing that? It's, it can be overwhelming, but at the same time, it's hopefully the best time of your lives in which you get to learn and learn and learn. And I hope that one day you look back with great fondness for these years that you're having now. When I was in medical school, I went to medical school in Queen's University in Canada. And I remember our very first, if I talk too much, let me know. Sometimes jet lag makes me talk too much. I remember our very first neuroscience lecture, and all these pathways and so on. The lecture ended, and I felt I was like, oh my God, I'm already behind. So there was just so much. The information was overwhelming. But at the same time, now that I look back, and I know I at the time as well, obviously I was very much enjoying it. They were literally the best years of my life. I only had one responsibility, and that was to study and to learn. And this is such a beautiful time. Once you move out of this, you'll have many more responsibilities, and some may have those already, but you're likely to have more responsibilities, not less. You'll have clinical responsibilities, family responsibilities, financial responsibilities, administrative responsibilities, emails about this and that that's late and so on. Right now, it is just understanding and learning. So that's a really, really beautiful time of your life. I also remember when I was a senior resident, I was operating with the staff, and he said, senior residency was the best year of his life. I just looked at him saying, what planet does he live in? It was so busy. I mean, we had cases all the time. I would not leave the hospital in 2 or 3 days. Exhausted from so many calls and so on. But he wasn't wrong. He wasn't wrong, because again, as a senior resident, I had one responsibility: my patients. So these are, I think, key times of our lives that, as I said, we connect the dots later. But hopefully you can learn from that and connect the dots now to understand that this is a very, very important part of your lives. So enjoy it, be curious, have the opportunity of speaking with people and figuring out, can I learn this technique? Looks like, for instance, engineering, bioengineering in this field is moving ahead, so then I'll spend a bit of time understanding it. And people are there to support you, to provide you with opportunities of research and learning, and maybe traveling and seeing how things are done and attending conferences and so on. And don't feel shy, if I can say, about emailing people and connecting with someone who might be an expert in the field, and maybe they will answer, maybe it will work out, maybe it won't, but if you don't contact them, you'll never know. So seek out these opportunities, and they will come for you.